Tēnā koutou katoa and welcome to the Hospice New Zealand Breakfast webinar held in partnership with My Health Hub. The presenter this month is Professor Paddy Stone, Head of the Marie Curie Palliative Care Research Department at University College London and the Honorary Consultant in Palliative Medicine at UCL Hospitals NHS Trust. His topic this morning is prognosis in palliative care, including the role prognostic information and communication play in reducing the prevalence of burdensome treatments at the end of life. Also, prognostic algorithms, prognostic accuracy, and clinical predictions in palliative care. And also recommendations on prognostic communication and future research directions. So thank you, Paddy, for joining us today from London, and a warm welcome to you.
Well, thank you very much. It's delightful to be speaking to you all. I'm just obviously terribly disappointed not to be there in person, because that would have been a spectacularly nice way to be spending the morning. As it is, I'm in my office upstairs at home in Wimbledon. So greetings from an autumnal evening in South London. I'm going to be talking about prognosis in palliative care. Thank you very much for the introduction. I do apologise because there's one thing there that you mentioned that I would be covering, which I won't be covering, and that is communication. So I did think about trying to cover communication in the 40 minutes, but I decided that would be a bit too much of a squeeze. So I'm happy to answer questions about communication, but I'm not going to specifically cover it in my talk today. I'm going to set the scene by talking about the importance of prognostication. I'm going to spend quite a bit of time talking about clinical predictions of survival. Then going to talk about prognostic algorithms, and the main meat and bones of this presentation will be on the results of the Prognosis in Palliative Care Study 2, the PIPS 2 study. And I'll finish with some conclusions and recommendations. So why am I talking about prognosis? I think this is an issue which is of importance to clinicians. It's a frequently asked question which we generally feel uncomfortable answering. And if you look at observational studies or qualitative research, you often find that when patients make cues in their consultation, if not asking explicitly about prognosis, often, not always, but often those cues or those half questions fall on deaf ears, and clinical staff often try to avoid or evade answering prognostic questions, and that's partly because we feel uncomfortable doing it, because we don't feel that confident in making prognostic estimates. But these prognostic estimates are important because they will influence the decisions that clinicians make about how actively or aggressively to treat patients, and unrealistic prognostic estimates from a patient's perspective can affect which treatments they're willing to accept. There are other potential uses for prognostic, improved prognostication, including, for instance, prioritization of referrals, deciding who should go top of the list to be admitted to the hospice for terminal care, deciding who gets access to certain benefits in certain countries. Certainly in the UK, if you are diagnosed as having a terminal illness, you get access to special benefits, and it may be useful in research studies in stratifying patients to make sure that groups are equally balanced. But of course, this isn't just about clinicians. It's not really even mostly about clinicians. Prognostic information is of supreme importance to patients and to their carers. We know from the research that patients who are unaware of their prognosis, or who have a distorted view of their prognosis, are more likely to prefer aggressive care. By that I mean burdensome, intrusive care, which may or may not be of any value at this stage in their illness. They're not only likely to prefer it, they're more likely to receive it. They consequently are more likely to have a worse quality of life. They're less likely to engage in advanced care planning and complete advanced directives. They're less likely to receive care which is consistent with their preferences. And in particular, they're less likely to receive access to hospice or palliative care. So improved prognostic awareness, improved prognostic accuracy, improved prognostic communication, all of these things I believe to be of great importance for improving the care of our patients. Now, the way that we normally make prognostic estimates in palliative care is to use a clinician prediction of survival. We look at the patient and we make a decision about whether we expect the patient to live for days, weeks, months, years. And some of you may be familiar with this type of image. This is one of a number of systematic reviews which compared clinicians' predictions of survival with actual survival. Each of these bars on this chart represents a separate study, and bars which extend to the right represent those studies in which the clinician over-predicted how long somebody was going to live. And bars that extend to the left are those studies in which clinicians under-predicted survival. And without looking at the details of this slide, you can immediately get the impression that most studies show that clinicians overestimate survival, that they're generally inaccurate, sometimes really quite markedly inaccurate. And that is, if you like, the headline story about the accuracy of clinicians' predictions. However, I just want to put a bit of light and shade on this issue, because I don't think it's quite as straightforward as that. For a start, most of the time when we make predictions, we don't make a quantitative prediction. We use qualitative language. We might say things like the prognosis is good, bad, or uncertain, things are getting worse, time is short, those sorts of things. Now, those things definitely carry factual information. They do convey genuine information to a patient, but they're not the sort of prognostic estimate which you can evaluate in a study. So for a start, we're missing out on those sorts of statements. The other thing is that these studies that I've reported in that systematic review often are not very clear about who is making the prognostic estimate. Was it made by expert professionals, by junior staff, less experienced staff? Was it made by a doctor, a nurse, or a multi-professional team? Furthermore, there are some difficulties with interpreting these studies because of the way in which the prognostic estimate is obtained in the study. So you could ask a very open-ended question. How long do you think this patient will live? And I might say, I think they're going to live 3 weeks. Well, what if they live 3.5 weeks? Does the author of that research paper say that my prediction was inaccurate? Or how do they decide what the level of inaccuracy is which justifies deciding that it's inaccurate? One way some authors get around this is to group prognostic estimates and say, well, do you think they're going to live less than a week, 1 to 2 weeks, 3 to 4 weeks? And then if your estimate is out by a category, it's deemed to be inaccurate. But once again, I think, you know, if I say I think somebody's going to die within a week and they die within 8 days, I don't know that that's a terribly impactful or meaningful mistake in my prognostic estimate. Even more difficult is probabilistic estimates. What does it actually mean if somebody says that they think there's a 90% probability that a patient is going to die within 2 weeks? If the patient dies, you can say, well, my prediction was correct. But then again, if the patient doesn't die, you could also justifiably say, well, look, I said there was a 10% chance they wouldn't die within 2 weeks, and this patient's one of the 10%. So how you exactly define these estimates defines whether you decide that clinicians, how accurate they are exactly. So the simple answer to the question is, as stated at the beginning, clinician predictions are inaccurate and over-optimistic. The more complex, and as usual in life, the more complex answer is the more accurate answer, is that it depends on what you actually mean by a clinical prediction. Who made it? How did they make it? What sort of prediction was it? And it depends what you mean by accurate. Did they have to be accurate to within plus or minus 33%, plus or minus one category, or do they have to get it bang on the nail? The alternative to clinician predictions of survival is to use prognostic algorithms. And algorithms is just a fancy term for a formula. It's a mathematical formula for predicting survival. And over the last 25 years, lots of prognostic algorithms for use in palliative care have been created. And I'm not going to have time to go through all of them. It wouldn't be very informative to do so. So I've picked 3 to talk about in a little bit more depth. The one that you may be most familiar with is known as the PAP score, or the Palliative Prognostic Score, first published in 1999, which makes it very last century, but a very well published tool, lots of literature about it. I don't know how widely it's actually used in clinical practice. Probably it's the most widely used in clinical practice. It's a pen and paper score. You can calculate it in your head or on the back of an envelope. If you've got a patient with breathlessness, you score a point. If they're anorexic, you score 1.5 points. You get points for hematological parameters, for the Karnofsky performance status, the KPS. But crucially, there's a large weighting given to the CPS, which is the clinician prediction of survival. And not just any clinician prediction of survival, but the clinician completing the score is asked to make a prediction to the nearest 2-week interval. You tot up all of these scores, you get a total score, and you then can read off from the total score the probability that the patient will live for 30 days. And you're in one of 3 risk groups. Either you're less than 30% chance of surviving 30 days, greater than 70% chance of 30 days, or somewhere in between. And this tool has been validated in lots of situations, and generally those categories hold true. So it does what it says on the tin, and we'll look at that in more detail when I give you the results of the PIPS-2 study. But personally, I have a couple of reservations, I think, about the PAP score. I think it is a good score, but I have some reservations. One is that the times when I most want to use a prognostic score are precisely those occasions when I'm least certain of my own judgment about how long the patient is going to survive. I therefore find it quite frustrating when you go to the PAP that you're constrained to make a really quite accurate clinical prediction. And that prediction is the single biggest contributor to the overall score. So I find that on a personal level a limitation. I also question how valuable the output is of the PAP score. Just for a moment, imagine you're a patient and you've been told that you're in risk group B, 30 to 70% chance of surviving 30 days. What does that mean? I wouldn't know how to interpret that. Does that mean I am or I'm not going to survive 30 days? Does it mean I'm going to survive about 30 days. What does it mean? Even the other categories, a less than 30% chance, to my mind, isn't quite enough probability. I mean, I'd like to know you've got a less than 10% chance or a less than 5% chance. It depends what sort of decision you're wanting to make. Is knowing that it's a less than 30% chance sufficiently certain to make your clinical decision? Another score is the Palliative Prognostic Index, and this is works on the same principles as the PAP, but whereas the PAP produces a probabilistic outcome, the PPI makes a specific prediction about whether patients will live less than or more than 3 or 6 weeks. The other difference with the PPI is that it does not involve the clinician prediction of survival. So that's taken out of the equation. Same principles though, you tot up your score, you look at your score, and the PPI will make a specific prediction about whether you're going to live less than 3 or more than 3, less than 6 or more than 6 weeks. And the other score I want to talk about is the PIPS score, the Prognosis in Palliative Care Study Predictor Model score. This is a scale which myself and colleagues created about 10 or so years ago. There is a PIPS website on my university webpage you can have a look at if you want to find out a bit more about it. But it's basically works on the same principle as the PAP and the PPI. The only difference is that unlike those scales which you can just calculate in your head, the PIPS models contain many more variables, and the formula for calculating the total score is a little bit more complicated. But in essence, it's exactly the same. But rather than calculating the score on a pen and paper, you go to the website and you put in the answers to these variables, and behind the scenes it will calculate the score and spit out the result. There are 2 broad categories of PIPS scores. There's the PIPS A models, which are suitable for all patients in the sense that you don't need a blood test to calculate the PIPS A score. And I created a score like that because I was aware that in my own practice, there are occasions where it really wouldn't be very ethical or appropriate to take a blood test from a patient just to determine whether or not what their prognosis was. But the PIPS B models additionally include information from blood results. So one is for potentially suitable for everybody, and the B models are really only suitable where a blood result is available. If you go to the website, you enter some data, you get an output. Now the PAP gives you an output on the probability of surviving 30 days in 3 categories. The PPI gives you a prediction about whether you'll live 3 or 6 weeks. The PIPS makes a specific prediction whether you'll live for days, and that means less than 2 weeks, so 0 to 14 days. Whether you'll live for weeks, which means 2 weeks to 2 months, or whether you'll live for months, meaning 2 months or more. As well as making a prediction about how long, it will also give you a percentage probability of surviving to each of those key time points, 14 days and 56 days, which is 2 weeks and 2 months. So before I talk about the results of studies evaluating these tools, it's important just to understand a little bit about the technical jargon. The way you evaluate a prognostic model is by looking at 2 factors. The first is discrimination. That's how well a score or a scale can distinguish between groups with different prognoses. So for instance, if you have a prognostic score, does it line, does your score provide a higher score for patients with a poor prognosis and a lower score for patients with a better prognosis, and consistently put people in the right order? And calibration is the agreement between the prediction that the model makes and the observed outcome. In other words, does the patient die or not? to make this more understandable, imagine you had a thermometer and you don't know whether it's working properly. The way you would assess the thermometer's discrimination is that you would take 10 pots of water of known temperatures, 90 degrees, 80 degrees, 70 degrees, 60 degrees, etc. You'd put your thermometer in and you'd see whether it gave a higher reading consistently for the pot of water which was at a higher temperature. And if your thermometer consistently always showed that the pot that was at the higher temperature always had a higher reading, then that shows excellent discrimination. But it's important that you also check the calibration of the thermometer. So it may be, for instance, that it consistently puts them in the right order, but the pot which is at 70 degrees, your thermometer reads it as 75 degrees. And the pot which is at 30 degrees, your thermometer reads it at 25 degrees. So every reading is wrong, but they're all in the right order. So that's a score which would be showing good discrimination and poor calibration. You want a model which does both. So the PIPS-2 study is the validation study for the Prognosis in Palliative Care study predictor models. You need to know that there was a PIPS-1 study, obviously. That was the study in which the prognostic models were developed. And I'm just going to dig down a little bit more to explain that the PIPS-A models, which remember are applicable potentially to all patients, it's actually two different models. There's one to predict 14-day survival, the A14, and there's one to predict 56-day survival, the A56. And there's a decision rule that combines those two models that makes a specific prediction about whether the patient will live for days, weeks, or months. And the same applies to the PIPS-B model. In the PIPS-1 study, we developed and validated that model. In the PIPS-2 study, which was twice the size in 27 palliative care services in the UK, we validated the PIPS models in an independent cohort. And we also looked at the PAP score, the PPI score, and some other prognostic models, which I won't have time to go into today, the Filia prognostic nomogram, the palliative performance scale, among them. We spent a lot of time in the PIPS-2 study finding out about the clinician's prediction of survival, because we wanted to compare the accuracy of these prognostic algorithms with the accuracy of the clinical predictions of survival. So we asked quite a lot of information about the clinicians who were making the predictions. How experienced were they? When did they last see the patient? We asked them to make a broad prediction about whether they thought patients would live for days, weeks, or months, using those cutoffs which I've described previously. We then got them to give a much more specific prediction, akin to the type of prediction needed for the PAP score. So we asked them to predict to the nearest week how long patients would survive. We also got them to predict the probability that patients would live to a certain time points. Not only that, we got doctors to do it and nurses to do it independently, and we got doctors and nurses to put their heads together and come to an agreed professional estimate. So we got lots and lots of information about the clinical prediction of survival. Well, how did the various prognostic tools perform? Well, the good news is that the PAP score, as I said, did exactly as it was designed to do. It divides patients into three groups. Group A, which is the best prognostic category, are predicted, if you remember, to have a greater than 70% chance of surviving 30 days. And we found that that group A did indeed have a greater than 70% chance of surviving 30 days. In fact, they had an 87% chance of surviving 30 days. And similarly, the other prognostic categories were exactly as advertised. So group C did have a prognosis of less than 30%, or a probability of surviving 30 days of less than 30%, and the intermediate group were intermediate. So this looks like the PAP score basically has been validated because it does what it says on the tin. The only fly in the ointment really for the PAP is that we asked the clinicians to also predict the probability of patients surviving 30 days. And when we grouped the clinicians' predictions alone, we found an almost identical, I mean, you really couldn't tell those graphs apart, almost identical survival curves. So in other words, the clinicians were equally able to divide patients into those three broad groups. The group that they said had a greater than 70% chance of surviving 30 days did have a greater than 70% chance of surviving 30 days. And in fact, it was almost exactly the same as proportion as identified by PAP score. So PAP is good. Clinicians are good. They're both equally good. We looked at the PPI. Now the PPI slightly different because remember this gives a prediction about how long, not the probability. In a way, when the question is how long, it's actually easier to compare. So we could just see if the clinician predicted they'd live more than 6 weeks or less than 6 weeks, more than 3 weeks or less than 3 weeks, and we could look at whether the PPI did that, and we could see how long the patients actually lived, and we could therefore see whether the clinician was correct or the PPI was correct. Now, obviously, sometimes the clinician and the PPI were correct. Sometimes the clinician and the PPI were incorrect. And there were these discordant cases where one was right and the other was wrong. And what you are hoping to see is that the PPI would have been correct on many more occasions than a PPI correct and the clinician incorrect on many more occasions than the clinician being correct and the PPI being incorrect. But sadly, we found the opposite, which was the clinicians were better, statistically significantly better than the PPI at predicting whether patients would live for 3 or 6 weeks. Then we come to the PIPS tools. The PIPS A tool, remember I did explain there are actually 2 tools there. One predicts 14-day, one predicts 56-day survival. The way we evaluate discrimination statistically is using something called the C statistic, and a value above 0.8 is regarded as excellent. A value above 0.7 is regarded as being good. So the PIPS A14 showed excellent discrimination and the A56 showed good discrimination. In other words, it would order people in the correct order according to their prognosis. It was also showed good calibration, good or excellent calibration. In other words, when it made a prediction about the probability of surviving 2 weeks or 2 months, those predictions were quite well calibrated. The final stage is that we combine the A14 and the A56 models to make a specific prediction about whether a patient will live for days, weeks, or months. And again, this looks pretty good because it divides patients into 3 groups, and they do indeed have survivals of days, weeks, and months. The days group has a survival of days on average, and the weeks group, weeks, etc. The fly in the ointment, just like with the PPI, however, is that when we directly compared the decision rule about how long somebody was going to live with whether clinicians could do that sorting into days, weeks, and months, was that the clinicians were statistically significantly better than the PIPS A decision rule. That doesn't negate the fact that the PIPS A14 and the A56 were both very good standalone measures, but the combination with the decision rule, which makes a specific prediction about whether you'll live for days, weeks, or months, clinicians do it better, according to the PIPS-2 study. With the PIPS-B tools, remember these are the PIPS ones that you can use with a blood result. They showed all-round excellent discrimination. Both see statistics in excess of 0.8. They also showed good calibration. There's a few occasions when it over-predicted or under-predicted survival, but generally you can see there is a good relationship between what was expected and what was observed. Once again, it's looking encouraging. We see 3 curves, distinct, and once again, if PIPS-B says that you're likely to live for days, the group on average is indeed likely to live for days, and the same applies to the weeks and the months. And when we compared the PIPS-B directly with clinicians, this time we found that there was no statistically significant difference. So in other words, the PIPS-B performed as well as the combined wisdom of a doctor and nurse. This was the benchmark we were comparing it with, doctor and nurse putting their head together. So it was as good as a specialist head-to-head decision by a doctor and nurse, but no better, no better than, no worse than, no better than. So what do I think the implications of the PIPS-2 study? I think, well, obviously, I would like to have been able to show that one of the tools we looked at was statistically significantly more accurate than the best predictions about how long patients would live by a multi-professional team. And none of the tools we looked at were. But some of the tools were worse. PIPS-A decision rule, PPI, were significantly worse. And I think, as a broad statement, if a tool is less accurate than a clinician prediction of survival, then it's unlikely to be of any clinical use. So unless the PIPS-A decision rule can be modified, or we just look at using the PIPS-A14 or the PIPS-A56 models in isolation, I don't think that they should be recommended for clinical use. And similarly, I'm reluctant to recommend using the PPI because of the findings in this study. However, it doesn't mean that there is no role for these algorithms, and they may be of added value. They may be of added value, for instance, if they're more accurate than generalist staff. Remember, the benchmark in this study, the PIPS-2 study, was specialist palliative care staff. Maybe these prognostic algorithms are better than other non-specialist staff. That's yet to be evaluated. They may have value just because they're objective. And so, in a sense, you can know that people aren't going to try and game the system. I'm just thinking here in terms of, I know that if you want to get a patient into a hospice urgently, there's a temptation, shall we say, to say that you think that the patient's going to die very soon. It's really a great priority. They must be admitted soon. Be much more objective if we just provided the prognostic score and let the hospice decide their own priorities, on the understanding that the prognostic score is at least as accurate as the combined wisdom of a specialist doctor and nurse. Similarly, using a prognostic score rather than clinicians' predictions would help stratify patients for entry into clinical trials, would help describe the case mix of your population. We could all speak a common language to each other when we describe the patients we're dealing with. So having a tool like that might be of value. It might have a value acting as a second opinion, for instance, in those occasions when I'm least confident in my own clinical judgment. They might help train less experienced staff in the factors to look out for in deciding a prognosis. Or they may act as a prompt or as a basis for framing a prognostic discussion, either with professional colleagues or potentially with patients or family. Or they may be of no added value, of course, over the clinician prediction. That is also possible. So what are my conclusions and recommendations? I think clinician predictions of survival, they do have limitations. And that bold statement at the start that they're unreliable, they're inaccurate, they're over-optimistic is true, but do take into account all of my qualifications about why I think that sometimes those studies are not fairly interpreted, particularly about what's the acceptable margin of error. Because to my mind, we're not really trying to make a prediction about exactly how many days somebody's going to live or exactly how many weeks somebody's going to live. What you want, or what I think patients want and families want, is a prognosis which is accurate enough. It's good enough to act as the basis for an informed decision or to help with advanced care planning. People don't need something which is spuriously accurate and which may well turn out to be incorrect in any case. There is the question then of whether prognostic tools may have added value, even if they're no more accurate than clinician predictions of survival. And the only way we'll really get down to answer that question is to do what's called an impact study. And that would be in the form of a randomized controlled trial where one group are exposed to usual care, which is generally clinician predictions of survival, and the other group are involved in a enhanced prognostic disclosure arm, if you like. And we could evaluate whether the care of those patients was in any measurable way better for the use of the prognostic algorithm. So that's an impact study. Now, no prognostic impact studies have been undertaken in palliative care. We've only got as far as evaluating tools for accuracy, but not for impact. And that really, I think, is the next frontier in prognostic research. So thank you very much for listening. And I'm going to stop sharing now and be happy to take some questions from the audience.
The first one is, my understanding of PPI is that it was developed mainly from oncology settings. Could you comment on performance, these algorithms in cancer patients versus non-cancer patients?
Yes, sorry. So there's a great first question, because this talk has basically been about advanced cancer patients. So I do apologize. I didn't make that significant, clear enough at the start. Some of these tools have been used outside of that indication, but the tools that I've spoken about were specifically developed really for cancer patients, all of the three, PAP, PPI, and PIPS. Some of them have been attempted to be used outside of those indications. Also, it's interesting to note that in the PIPS-2 study, we had what you might call classical palliative care patients, but we also had a significant number, several hundred patients, who were still receiving some form of active therapy, be that palliative radiotherapy, some form of palliative chemotherapy, hormone therapies, immunotherapies, but they all had advanced progressive disease and they were receiving palliative treatments only. What I haven't had a chance to do yet, other than for PIPS, is to look at the performance of these models only in the palliative care group, taking out the patients who are still on treatment, or conversely, only looking at them in the patients on treatment.
Thank you. And there was a question that came up earlier in the chat, which I'll read out to you. Somebody was hoping that you might refer to the gold standards framework, which seems useful as it is broadly disease specific.
Yes, or it's yes, it covers different diseases. The gold standards framework, you mean the prognostic indicator, or they changed the name of it, didn't they? It used to be the prognostic indicator guidance, or PIG, and they changed it to or something else, proactive indicator guidance, I think they call it now. It's not been validated. So that's why I've not really referred to it. People haven't looked at those variables prospectively and tried to evaluate how accurate they are at predicting survival. And also they don't necessarily give you a quantitative prediction about survival. They give you a qualitative one. So they might list various factors which are poor prognostic factors. And that's fine, because for the GSF, it's about asking yourself the reflective question, would I be surprised if this patient were to die in the next however long? And you're not using those prognostic indicators to make a specific prediction that's falsifiable. You're using it to raise your awareness of the fact that the patient might be somebody who's approaching the end of life.
Thank you. Another question is, my understanding of the PLOs, one systematic review was that the subgroup analysis showed no group of clinicians was no better at predicting prognosis. How would you persuade non-specialists to use the tool?
Yeah, well, I think actually just at the moment, I'm not sure I want to persuade non-specialists to use the tools, because I don't know whether that would be a good thing or a bad thing. I think we do need to do more of the research to determine whether encouraging non-specialists to use prognostic tools would be a good thing. I mean, I would worry in the wrong hands that people would have an not over-reliance, an undue trust in the output of an algorithm, because it's an algorithm, and wouldn't be aware that actually just because it's come from an algorithm doesn't mean it's any more accurate than asking your palliative care colleague how long they think the patient is going to live. And if you don't bracket any prognostic estimate with due deference to the uncertainty which surrounds it, you could run the risk of causing harm, I think, to patients and to families if you just put the numbers into a prognostic tool and said, by the way, this says that you're predicted to live for days. So so yes, I'm not sure that I'm not evangelizing yet that everybody uses these tools. I think that they should be used under caution at the moment.
Thank you. And how well do these prognostic tools perform in people with dementia, Paddy?
Well, these particular tools are not evaluated because they were developed in cancer patients. My general understanding of dementia prognostication tools is that they are not very accurate, and it's proven very difficult to identify how long patients with advanced dementia are expected to survive. More difficult, I think, than in many other illnesses.
Thanks. To determine prognosis less than 6 months to access assisted dying services, is it recommended to use a prognosis predicting tool or clinician's estimate?
Oh dear. Well, I would. Is that the stipulation? It's less than 6 months. Is that the legal position?
I don't know. It sounds like.
I don't know where that. Yeah, I would say I would be very wary of anything that relied. We talked about the perils of an over-reliance on these things, and when it comes down to a matter of life and death, about deciding whether or not somebody's eligible for assisted dying, which is a one-way ticket, I'd be generally very circumspect about relying on either clinicians' predictions or algorithms, I suppose would be my position. Mm. I would certainly feel very uncomfortable if somebody used one of the prognostic algorithms and said, oh, well, there we go then. This patient's definitely got a prognosis of less than 6 months and therefore would be suitable for assisted dying.
Thanks. And can you advise us if during the study Were the patient or family's thoughts or predictions taken into account?
So in the PIPS-1 study, we did
Yeah.
exactly that, actually. We, not families, but we asked patients whether they had any intuition about how long they thought that they were going to live. And we asked them whether they were willing to share that information as well. And in the PIPS-1 study, there were 1,000 patients, and about 250 of them said that they thought they knew how long they were going to live, and they were happy to share their intuition. So we asked them to predict whether, you know, how long they would live. And what we found is those people who were willing to share were very inaccurate. They were more inaccurate than the doctors or the nurses, and they were more optimistic than the doctors or the nurses. Now, of course, that may be a feature of the fact that it was a small subsample, because it was only the 250 of the 1,000, and it may be it was only the only people who wanted to share their intuition were the optimists, and the others didn't want to say it out loud because there is this fear of the self-fulfilling prophecy. And so I think maybe in terms of what people want to share, it's the optimists who want to share, and the pessimists who'd rather not.
Thank you. Who were the clinicians and what were their experience?
Sorry, who were the clinicians?
Who were the clinicians and what was their experience?
So they were the attending doctors or nurses on the wards or in the hospice at the time that the study took place for each patient. We collected information about their age, gender, years of experience, years of palliative care experience. Obviously there was a spread, and in amongst there would have been some junior and less experienced doctors. But when you look at the median values and the general description, these were generally doctors and nurses with over 15 years of experience and with 10 years or more experience of palliative medicine. So they were generally quite experienced doctors and nurses.
Thank you. Now, this is specific to our legislative environment this one. Given the End of Life Choice Act is coming in a month, what is your opinion on our ability to prognosticate 6 months or less? Do you know?
Not great. I think it's like weather forecasting, really. You know, there's this thing called the horizon effect, which is that, you know, predicting whether somebody's got hours to live. I mean, I could give you this data from the PIPS-2 study. I didn't go through all of the clinician results, but actually, you know, clinicians are pretty good at predicting when somebody's got a week to live. So days to live, short days to live, predicting whether somebody's got 72 hours to live. We're pretty good, high positive predictive value. If I say I think somebody's likely to die in the next 72 hours, with about 80 to 90% certainty, they probably will die within a few days. There will be actually a lot of other people who do die within a few days who I don't spot. So my sensitivity for picking those people up is quite low, but my positive predictive value is very high. That's fine when it comes to days or a week. But just like trying to predict the weather 6 months ahead, trying to predict with any accuracy survival 6 months ahead is a completely different ballgame. So I would say, certainly if somebody's imminently dying or they've got a very short prognosis, I'd feel relatively confident. But somebody who's got months to live, predicting whether it's going to be less than 6 months or more than 6 months, I think is anybody's guess.
Thank you. Do you know what impact on clinicians and patients? Sorry, do you know what the impact on clinicians and patients is with the converse when patients vastly outlive short prognoses?
Yeah, I'm just struggling trying to retrieve from my memory what research there's been on that. The honest answer is I can't remember about research, but I can give you anecdote. I'm sorry about that. But I do know that when there was the furore around the Liverpool Care Pathway in the UK, that a number of the complaints focused around inaccurate prognostication. And that worked both ways. Either families who were convinced that doctors had got it wrong and predicted that their loved one was dying and they didn't think that they were dying, or conversely, they said, oh, well, the doctors said they were dying, and that, you know, they went on to live for months, you know, or the converse, nobody told me. The first thing I heard was they were on the pathway, they were dead a few hours later. Why did nobody tell me they were expecting the patient to die? So I think a lot of the complaints around end-of-life care, admittedly, this is around communication, but they come down to either they didn't tell me that they were going to be dying imminently, or they got it wrong.
Thanks. And Bridget says, why would you use a tool you have discussed today instead of the KPS?
The Karnofsky performance status. Well, the KPS shows good discrimination. So the KPS will align patients in order. People with good KPS survive longer than people with poor KPS. But just knowing that somebody's KPS is 70% doesn't tell you exactly how long they're going to live. So if you want to put a temporal estimate on it, or you want to put some more flesh on the bones, KPS will be a good way of balancing groups in a randomized trial, for instance, or describing your case mix. They may be good ways, but they won't actually give you a specific prediction about how long or the probability of patients living to a particular time point.
Thank you. And the last one is, oh no, two more. Was there any study in aged residential care with these tools?
Not to my knowledge. Aged residential care, so care homes.
Yes.
Yeah, not to my knowledge, and because they're cancer-specific tools, I doubt that anybody's specifically done a study that just looked at care home patients, most of whom are dying from non-cancer diagnoses, usually in a care home, often dementia.
Thank you. And did any of the studies differentiate between clinicians' speciality, doctor, nurse, etc.?
Yeah, so we looked at that in this study, and other people have looked at it. I would say actually some studies show that doctors are better than nurses, and some studies show that nurses are better than doctors. Our studies have shown that doctors and nurses, when they put their heads together, are slightly better, not much, but significantly better than a doctor or a nurse acting alone. So I think that there's some evidence that the combined wisdom is better than a uni-professional estimate. But there is mixed data about profession. There's also mixed data actually about discipline, you know, palliative care versus oncology. And there's also mixed data about experience. It isn't always necessarily the case, or at least the evidence doesn't categorically state that the more experienced you are, the better you are. Sometimes it may be a bit like the emperor's new clothes. Sometimes it's somebody who isn't that expert just walks in and goes, my goodness, that patient looks shocking. They look like they're about to die. And everybody else has been, oh, no, they're going to be fine. This is just the side effects of the treatment, you know, and they're going to pull through this and they're going to be great. So you would expect the more expert to be better, but it's not necessarily the case.
Thank you. Another question has come up. You have said that the most accurate estimate of prognosis is specialist estimate. Exactly how accurate are they in terms of sensitivity and specificity?
Well, I can't give you the answer to that just off the top of my head, I'm afraid. One reason for that is that sensitivity and specificity apply to binary outcomes. So yes or no, did you survive 2-3 months or not? Then you can calculate sensitivity and specificity. You can't do that with 3 categories, for instance, without collapsing the categories. So, and our main outcome in the PIPS-2 study was looking at days, weeks, and months. So actually, sensitivity and specificity don't naturally lend themselves to a 3-category approach. But the data is there, and I could tell you if we just looked at what's the sensitivity of a doctor's prediction that a patient will live for months, for instance. That data's there, but I'm sorry it isn't at the top of my head. I apologize. Don't necessarily, you know, we talked about the shortcomings of the one I focused on that didn't perform very well was the PPI. That was in my study in the population that I looked at. Now, I wouldn't want to make a sweeping statement that the PPI should never be used in other circumstances or in other populations. So do bear in mind the limitations of the PIPS-2 study itself, which is that, again, it was looking at a mixed population, some of whom were on treatment and some of whom weren't. It may be that the PPI performs better in one or other of those subpopulations.
Oh, thank you, Paddy. Lots of nice comments coming in. Paddy, you can't see them, but on the chat now, there's a very real indication that this has been a hugely useful presentation. So thank you again for coming. I know it's evening time for you. I hope you enjoy the rest of your evening there in London and Wimbledon with Wombles. And and thank you, everyone. I'll close the meeting now.
Great. Thank you very much. Thank you.